Good day. My name is Kanyemba from Desmond Tutu HIV Foundation in South Africa, and again represent the South African National AIDS Council under the LGBTI community.
All right. I am Morenike Ukpong. I'm from Nigeria. I work with the Obafemi Awolowo University, actually, but the love of my life is other things I do on HIV and community work. And today, Brian and myself will be discussing our perspective about the things we've learned at the 2015 CROI. It's going to end today, but there's been so much information shared, and we want to see how and discuss how those information, those lessons, those experiences would inform our practice in the field when we get back home. Brian?
Yeah, it's there've been a lot of information that have coming out from CROI. Actually, one of the main issues whenever we're talking about co-infection and retroviruses is this huge scientific meeting, and you're like thinking, how am I going to understand all this? But fortunately enough for us, there have been really good, tremendous results that have been released so far. So specifically, one of the I'm going to talk about at least three of the studies and again one that is just that has just come out like an hour ago, and then I will discuss from there. So the first one is a study that has been conducted by a group in Europe called IPERGAY. So this study was conducted with among white gay men, and the results of this study were very good, with up to 86% of protection for those who are using it every time. And the other study again that was conducted by the PROUD study team in Europe, in Britain to be precisely, they actually did this another study again. The difference between these studies was you start at PrEP today, and some of the other group was going to be started in 12 months down the line. But again, something that is more interesting about it had a very tremendous results with up to 88%.
Which one was this?
That is the PROUD study.
The PROUD study, okay.
Yeah, which is so interesting because in 2010 we had the IPERGAY study again for MSM, which had 44%. So we can see now we have gone from 44% up to 86%. You know, it's really interesting, which means that if MSM gay men around the world are taking this medication every time as needed, they will have up to 100% protection, which means a lot in our community, especially in Africa, where the burden of HIV lies predominantly among young MSM. And again, it's going to tell us, inform policy. I understand that here in the US, the FDA is already regulated the use of PrEP, Truvada as prevention, and I understand the EMA in Europe is actually planning again on regulation, which is going to actually push Africa to actually regulate it. In South Africa, about 2 years ago, Gilead Sciences actually sent a letter to the Medical Research Council and Medicine Control Council of South Africa to actually talk about what about regulation. So I think these studies that were presented today at CROI will actually give more information on this.
Yeah, Brian, I see your excitement, but I don't feel that optimistic. I do agree with you that the PROUD study and IPERGAY study will result in licensure of tenofovir for use for HIV prevention within Europe. US is already licensed, but I'm not that optimistic in terms of Africa as a whole. South Africa, yes, I did learn that South Africa already has some guidelines in that respect. But for me also, one of the things from this conference that takes home and gets a little bit worrisome is the consistent inability to be able to find protection for young girls. that in Africa also has exceedingly high risk, probably comparable to even what we see in MSM. But unlike what you see in MSM, the young ones, like data has been showing us, are increasing in prevalence. The general public, it's down, but with young ones. So they become peculiar, all right? And the studies here isn't promising, not because the products are not effective or efficient or cannot reduce the risk of HIV, but there's something about the social context of the lives of young persons that is not. So I'm sure you also noticed that. Do you have anything to say about that? Yeah,
it's really a kind of bummer, like reduce your momentum of excitement, because really comparably the drivers of HIV, or where HIV is so dominant, is among young girls as well, and we really need to find what are these causes. Issues of poverty, issues of unemployment, issues of housing, issues of violence, and all that. So especially on this study that was being conducted, the FACT 001, these were young women below the age of 25, and
on the average.
on the average, and most possibly are just coming out from school and possibly still studying, and most of them are still under parental care, or same with boyfriends and all that. So possibly those are the things that possibly might. How can you use a product when you're sharing a room? How can you use a product when you are like you don't have anywhere to have sex? And would you go and use it behind a tree or somewhere else? So there are a lot of issues that possibly we need to find a product that is conducive to use to young women. Is it possibly put it in a sexy tampon, or is it putting it in a drug form, or is it putting on a gel? I mean on a ring form? Of which I was just thinking, what would be your perspective, especially onto other interventions, especially for these young women, and how would be those interventions be like?
I think that's a very big question for not just the researchers, but for we as communities.
Yes.
More recently, I conducted a study with colleagues in Nigeria where we're looking at adolescents 15 to 19, looking at the existing demographic survey data in the country. And it was very clear. Three major findings. One, HIV prevalence among adolescents had gone up. We feel what fed into that is the high, we have a very high rate of mother-to-child transmission, and so we're having this number of adolescents who are now moving into children that were born HIV positive that is moved into adolescence, and maybe that's what's driving. But this is a household survey that shows increase in prevalence. But two striking things. One, there was increase in the use of condom, significant. However, there was increased transactional sex, significant. So we're seeing a drive, and within the context of that evidence generated from demographic data, that we're seeing increase, proportion of females especially, significant over a 5-year period, that now increased in transactional sex. I think that becomes a risk factor, not because, not necessarily because they don't use condom, but then we might be seeing unplanned sex within those transactional sex that is occurring. It's true I might want to go buy sex, but maybe it's not all the time that those transactional sex. So I think in going forward, it's not just about gel, it's not just about rings. Adolescents are a peculiar set of people. That sense of risk is different. That sense of adventure is more. And what is it that would fit into their lives beyond? I don't think as an adolescent I'm going to wear any ring.
I think one of the things that we are struggling with, is it in community and is it in research, is conducting these clinical trials. Do you think they should be better designed to meet the demand of young women?
I'm going to answer that question in a roundabout way. And I'm going roundabout based on the lessons I think we've learned from Ebola. One of the big dilemmas that's going on in terms of ethical debates around around Ebola is studies of drugs and how you do this. Is it supposed to be randomized? Is there supposed to be designed in ways that allows for compassionate use? And I think the lesson from me, taking it from Ebola and bringing it to HIV and this question you've asked, is that we need to stop being fixed in our way and our mind of conducting research and be ready to learn how to do research that fix the context of the lives of people. Randomized trials were designed by human beings. They didn't come from heaven. We designed them. Maybe now we're in an era where that form of design is not appropriate for the lives we live now. So I would like to see more and more of research being divulged from the fixed way of thinking about it. And then we start thinking of other ways of designing research in ways that answers the crucial questions of the lives of person. Am I communicating?
Yeah,
what do you think?
Yeah, I think that is really true. I mean, I would really say in African-led by an African woman who really understand the perspective, the lives that a woman is leading. I am not saying that people that are conducting studies are not doing the right thing, but I'm just liking to want to highlight that they have got the feeling, they understand where this woman is coming from, they understand the issues and problems that this young woman is seeing. And I think I am calling out there to the young women, I'm calling out there to Africans that this is a time now that we need to stand up as Africans and design what we need for us, say that we are the ones who understand the situation. We are the ones who know what we need to do next, because we didn't know about what is randomized. It didn't come from somewhere in Abuja or in Lubumbashi. It was designed, and we are all following this general clinical practice, which was designed elsewhere. What about from our own community? Say that we could know what to do. So I am really calling, let's go to school, let's study, let's put this into our own perspectives and see how we could work from there. But beside that fact, I think it would be great if we could actually talk about the results that have just come out a few minutes ago. It is really interesting. These results are South African perspective. This is where all the studies are being done. But actually, it means a lot, especially in the community that I work. And I think it is great if we could share them. So this studies, it was conducted by the NHLS, I think I pronounced it properly. They're actually presenting how many people are on treatment and how many people are on their viral load being suppressed and everything else. So I think we should remember that about 2 years ago, the President of South Africa launched the HCT campaign, HIV counseling and testing campaign, of which about 6.4 million were tested, actually 20 million were tested on HIV, and 6.4 million were found to be HIV positive. So the results today, we're actually looking into those 6.4 million, what has been happening since that, which I find very, 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 very exciting. What happened was, in the last, from 2010 to 2011, the last report was telling us that there are only 2.4 million on that 6.4 million people who are HIV positive. But today, interesting, exciting, the number is gone up by another million of 3.4 million who are actually on treatment by today, which is very, very exciting. And when the presenter was presenting, he actually presented how many people are actually being followed through to care, to virus suppression, which I found very, very fascinating, because of the 3.3 million that are of the 6.4 million that are HIV positive, 3.3, which makes 70%, are on treatment, and of that 70%, almost half are actually virus-suppressed, which is, to put on number, is always 1.7 million, which is actually over half of 3.3 million, which is so exciting. And it actually shows us where we are going, what we are doing, and something that is being done in other African countries. But really, Morenike, I really wanted to put this forward to you. This has been happening in South Africa, and a lot of things are happening in South Africa. Are there any kind of news, something that is being done in Nigeria or possibly in other countries, something like this? Because I really think South Africa is a global world. They all come, and possibly what will happen is we can be very surprised, but we've got Nigeria coming to South Africa as well.
I think the result you're talking about, I mean, or the analysis that has been shared at CROI conference in terms of in respect to what you're talking about, has been really encouraging and interesting, because what many of them are trying to show is in terms of relativity to their context and the 1990 goal declared by UNAIDS. What is it like? If you recall at this morning plenary, they also shared that kind of data with respect to female sex workers, and it was very clear that the 1990 goal cannot be met for female sex workers if there isn't concerted effort of moving female sex workers through the continuum of care with peculiar. I also think about what's happening in my country, and we don't have this data, but I also felt, wow, we might not have this data because we do have some improvement, but challenges in terms of collecting this kind of data, because you could see excellent triangulation of data. And I think it would be worthwhile for listeners to please check the CROI website and look for this data. It's exciting in terms of how we're doing well in terms of providing continuum of care for populations in terms of geographical populations, for populations in terms of community-based, like female sex workers, MSMs, and what that is telling us in terms of meeting the 1990 target set by UNAIDS.
Yeah, which is really interesting, because one of the things that you just brought now about on female sex workers, we said that we could understand there's a study that is being conducted right now in Johannesburg on female sex workers, especially on use of PrEP as well. So I think one of the things that we need to look at is we have got Nigeria, it has got coastal areas, and from understanding from data that has been presented about Mombasa, it's a high risk area on female sex workers. Can you briefly, as well towards the end, talk about that a little bit? Female sex workers in Nigeria? Yes,
I think that's excellent. One of the things we're seeing in Nigeria right now is the mobilization of female sex workers to address their own need, but mainly pushed by Global Fund. And when I listened to the presentation in this morning, she provided evidence to show that community empowerment impacts significantly on the risk and incidence of HIV. I think that was very powerful. And that community empowerment and mobilization is just starting to happen. So I'm sure maybe down the line we're going to be able to get those kind of data that she was able to share. But it's really, I was really happy to see that doing that. I heard very clearly from her that mobilization doesn't automatically mean loss of frequency, because sex is trade, and then coming together also means you're going to be trying to get your own space within that ability to work in a cohesive fashion, but it does happen at the end of the day, and getting there. So yes, Nigeria in terms of that movement is just starting, but it's exciting because with Global Fund support over the next year, we might be able to share those kind of data that
I think
share today.
I think thank you so much for sharing that. I think in closing, what I would want to say, and you've mentioned one important aspect, we have got Global Fund, we've got PEPFAR, and we've got other development partners in country, in Africa, who are supporting, and we really respect and thank them for the support that they are doing. But I still want to push that we as Africans, we should drive our resources towards an investment towards HIV, our own HIV response, because this way actually we'll feel the burden. if we do that. And I think it's so exciting to have this discussion. And thank you so much for discussing these issues with us. So, any last word that you want to say? Well,
my last word is that community has to stand up and advocate and be community. Two things. One, we heard we need African researchers taking forward our issues, and we need the African voice asking and demanding for our government to be responsible to us.
There you have it as community. Thank you so much for being with us today.
Thank you.